So earlier today we got started with cardiovascular pathology. We looked at your early cyanosis, the 5T congenital issues, and then we looked at the later cyanosis with the VSD, ASD, PDA, and we really got a good feeling for like how blood movement gets affected based off of what kind of congenital difficulty you have. So now the next few topics are all kind of bundled together. There's hypertension, hyperlipidemia, all of which eventually can lead to atherosclerosis. And together that's going to present with aortic dissection, aortic aneurysm, and then of course the notorious myocardial infarctions. Right, so all of that stuff ties in together because one thing leads to another, and it becomes ridiculous depending on how well you actually try managing it, how well you try to recover. Right, so as we go along, we'll show you more pictures, we'll talk about some other practice questions, and so on and so on. So hypertension is persistent blood pressure that's above 130 in the systolic area and above 80 on the diastolic area. So something higher than 130 over 80. Now, if you get someone with 140 over 90 or 140 over 100, these are definitely problematic blood pressure readings. Risk factors for hypertension, pretty much. The most significant risk factors for hypertension are pretty much your diet and your physique. So, obesity and excess salt intake, alcohol intake. Of course, smoking can affect your blood pressure because that directly causes damage to your blood vessels. And diabetes. Now, they have diabetes here, but diabetes only really matters if it's not well maintained, right? If you don't manage your diabetes with medications and a good diet. Otherwise, if you have diabetes that you manage very well, that's not really going to lead to hypertension. Alright, and family history is a big deal, and of course it affects African Americans more likely than it affects Asians, even though Asians are usually the ones who have excessive smoking history and excessive salt intake, right? Chinese people, for example, their diets mainly consist of very, very salty foods, and then of course majority of Chinese, Japanese, and Korean men and women tend to definitely be heavy cigarette smokers, right? So it's very interesting that it's actually still more likely to get hypertension in an African American than it is in an Asian. Now, this equation from earlier in physiology, right? Blood pressure is equal to cardiac output times total peripheral resistance. So if either one of these two things increase, your blood pressure will increase. Alright, so if you have more cardiac output or if you have a elevated total peripheral resistance, blood pressure will be higher. 90% of hypertension is just essential hypertension, primary hypertension. That's pretty much happening for no real reason. And it's going to be related to elevated cardiac output or elevated TPR based off of this equation right here. Remaining 10% is mostly either renal or renal vascular disease such as fibromuscular dysplasia. And this is going to come up later again when we get to MSK. We'll also talk about it again when we get to renal. So you're going to note a characteristic string of beads appearance of the renal artery like they show here, usually seen in women of childbearing age, so middle-aged women, and as well as in atherosclerotic renal artery stenosis or with patients who have primary hyperaldosteronism. Right, so this will be clarified more when we get into endocrine. So for fibromuscular dysplasia, look for a young patient with hypertension or hypertensive emergency with papilledema, headache, and epigastric bruit. Do CT angiography to confirm, right? And that's very important stuff. This is not an extremely rare thing. It actually occurs pretty commonly. So you have hypertensive urgency and hypertensive emergency, where emergency is obviously a bigger issue. In urgency, you just have really high 180 over 120 blood pressure readings or above that, but there's no end organ damage, right? No damage to the kidneys, no damage to the eyes, at least not yet. Eventually, though, that same thing can lead to evidence of acute end organ damage, where you have encephalopathy, stroke, retinal hemorrhages, papilledema, an MI, heart failure, aortic dissection, any of these things, because generally speaking what happens is your blood vessels start to rupture, they can't carry the pressure in there anymore, and then whatever organ they were going to ends up getting damaged as well because blood is going to come with extremely high pressures. Right, so now right here I have another image down here, this one, for the same thing. Right, you can see the string. Now the string of beads is extremely clear in this image. And this is another image showing the same string of beads, not as clearly, but this shouldn't look like this at all, right? So that's definitely a thing. And then the patient stem here gives it away. So this is NBME 23. A 36-year-old woman comes to the physician for a follow-up exam 1 week after being diagnosed with severe hypertension. Her blood pressure is in that range, right, 180 to 120. So that can be either urgency or emergency based off of whether or not she has end organ damage. Physical exam shows no other abnormalities. A CT scan of the abdomen shows a renal artery aneurysm. A renal angiogram obtained from a femoral approach is shown. And then you see this image. Which of the following is the most likely cause of these findings? Right? And the most obvious answer to pick was definitely fibromuscular dysplasia, because something's wrong with the angiogram, right? The vessel. So picking, for example, this student picked polycystic kidney disease. That really wouldn't make any sense, because the question didn't give you anything about polycystic kidney disease or PCOS even, and you can see cysts here. This is not a cyst, right? But if you don't think of fibromuscular dysplasia and you're starting pretty recently, then you could think maybe this is a cyst. But they already told you that this is an angiograph. You're looking at blood vessels, right? So there's no cyst here. And then the kidney itself is over here. This is all going into the kidney now. And there's no cyst visible, all right? So that's all this question was about. And this here is showing you papilledema. This is what papilledema looks like. And this is just the structure of an arterial wall. So you have the tunica intima, which is the inner aspect, media, and tunica externa. Right, 3 different tunicas. And the way on the inside, you also have endothelium. And there's 2 muscular layers. There's the internal elastic membrane, and there's an external elastic membrane. And in between is where you have your tunica media. Right, so those IE membrane and external elastic EE membrane are the pretty significant little membranes that are in between the two. They do show up in some anatomy questions, but not the most significant knowledge. Still, it's not that hard to remember the basic anatomy of a blood vessel, so that's there. And then we have a URO question right here. So, a 66-year-old man comes to the office for a routine visit. He has a history of hypertension and osteoarthritis. He smoked a pack of cigarettes daily for 40 years and occasionally drinks 1 or 2 glasses of wine, but does not use drugs. Okay. Blood pressure is 142/82 and pulse is 80. Cardiopulmonary exam is normal, and there is a pulsating central abdominal mass on physical exam. This is something you can definitely see one day at the hospital. What pathologic condition is the most likely underlying cause of his abnormal findings? And this was a very interesting question, because it's surprising how many people got it wrong. Right? Only 22% of people chose the correct answer, which was chronic chronic transmural inflammation, right? Chronic transmural inflammation. This patient clearly is having an abdominal aortic aneurysm kind of issue coming up, and that's when you start noticing the pulsating mass right there. So that's due to transmural inflammation. Transmural means it's across the entire wall, right? So transmural will be inflammation across this entire layer. 30% of people chose cystic medial necrosis, and anytime you ever see this kind of stuff, this should be ringing a bell for Marfan's, which this patient didn't have. And then you have focal intimal tear, which would be something that you would see in possibly hypertensive emergency, right? A tear is a dissection, so that would be like an aortic dissection, right? So that's the breakdown of how many people actually chose this URL question correctly and how many chose the wrong answers. His pulsating central abdominal mass most likely represents an abdominal aortic aneurysm, which is a focal dilation of the abdominal aorta, typically occurring below the renal arteries. AAA, abdominal aortic aneurysm, is associated with several risk factors that this patient meets, which is age over 60, smoking, hypertension, male, family history, and then being Caucasian is another thing, which they don't have here. Let me see if they put it into a book. Abdominal aortic aneurysm. No, they don't have it in the book. When I did my family medicine rotation, my doctor had told me you always want to look out for an elderly white male, right? White male. They don't have it in first aid itself. And the note I wrote here, I believe this came from USMLE RX. But yes, an elderly white male is usually, with smoking history, is usually the general audience you're watching out for in terms of AAA. So he meets a bunch of the risk factors either way. All of it leads to oxidative stress, vascular smooth muscle apoptosis, And chronic transmural inflammation of the aorta. You're just going to cause a lot of inflammation. That's it. Inflammatory cells, particularly macrophages, release matrix metalloproteinases and elastases that degrade the extracellular matrix components, elastin and collagen, leading to weakening and progressive expansion of the aortic wall. Furthermore, ischemia of the tunica media may play a role, as the infrarenal abdominal aorta has a tenuous vasa vasorum, and atherosclerotic thickening of the intimal layer increases the diffusion distance for oxygen. Right, so it's really important anatomy to remember that your vasa vasorum, right, they just mentioned something about infrarenal, right, below where the renal arteries are. Below the renal arteries, this is where you would get your abdominal aortic aneurysm. Let me see if I have a picture of the vasa vasorum stuff. No. Okay, let me just find something real quick. Vasa vasorum. Okay, so looking at Google, searching for vasa vasorum, we are seeing, let's see, with that, do they? So the real issue is the vasa vasorum itself generally only exists up here, right above the renal arteries. It exists up here, but not down here. So when you have inflammation of the abdominal aorta, right, the vasa vasorum really can't drain blood very well at all, and is unable to do its job correctly that far down. And that's why down there it's actually more likely to get an abdominal aortic aneurysm compared to in your aortic, in your chest area. What the fuck is that, man? Why am I blanking out on words? In your thoracic, right? In your thoracic aortic area, the thoracic aortic aneurysm is only going to have cystic medial degeneration, which was your other answer choice. Remember, we said that cystic medial degeneration, I said it should ring a bell for Marfan. Right, there's a big difference, so we're going to get to that, but this question was pretty much like a little prequel leading up to that. Right, so very important to remember, they're telling you he had an abdominal mass. This is an abdominal aortic aneurysm, and an abdominal aortic aneurysm is 100% just an answer choice of inflammation, chronic transmural inflammation. That's it. That inflammation is making the abdominal aorta really weak, and now it's going to have this pulsating mass because it's about to burst open. Like, this is a really big emergency, and this patient needs to be helped and probably have to do surgery for it ASAP before shit gets worse. And of course, give him medication for his blood pressure. That needs to be controlled because that's also just making the aneurysm issue worse. So now they start talking about hyperlipidemia, which is also closely related to hypertension, because when you have both things together, that's pretty much a concoction of death. So hyperlipidemia signs, there's xanthomas, tendinous xanthomas, and a corneal arcus, right? These are just general signs we've already kind of talked about when we were in biochemistry. Right? So you can see any of these things in any patient, and sometimes it's even harder to see them if it's a black patient. Right? It can actually be harder because these lipid deposits, they're not entirely yellow just because of the lipid itself. It's also the fact that this person has light colored skin. But if this person was a black person, this lipid deposit would not be the same color. It would still be a darker color, and at that point it becomes a little difficult to see compared to how you see it on a whiter person. And the corneal arcus, though, you can see in anyone, right? This blue ring, the blue ring around the eye, is not normal at all. Okay, so at this point right now, where we're looking at hyperlipidemia signs, one thing you definitely want to do is go back to biochemistry, right? Go back to the end of metabolism and check out those dyslipidemias, right? Familial dyslipidemias. So the first thing they taught you here was A-beta lipoproteinemia, where basically you're missing beta lipoprotein, right? You don't have the ApoB lipoprotein. So if you don't have B48 and B100, this is going to be a major issue with any management of LDL, right? So this is autosomal recessive mutation in a gene that encodes MTP, and chylomicrons, VLDL, and LDL are all going to be absent. Right, so the affected infant now presents with severe fat malabsorption, staturia, failure to thrive. Later manifestations can include symptoms of loss of fat-soluble vitamins, right? So that's all you're really going to care about. And the biggest issue is that they can give you this kind of slide, a blood smear that shows acanthocytes. Right? This is something that occurs because the patient has lost their lipids. Okay, so this is all you're really going to see. Nothing else in an infant for the most part. You're not going to get this question for a grown-up adult. Then you have your familial dyslipidemias, which are also there's only 4, but they're all very different, and they're extremely easy to memorize. Very, very easy to memorize. So you definitely want to give yourself that repetition to come back and look at it and master it. Type 1 is related to lipoprotein lipase, or C2. C2 is the cofactor for lipoprotein lipase. Lipoprotein lipase manages chylomicrons. Right? If you go back up to here, you can see C2, right? Chylomicrons. Right? Everyone works with HDL. HDL is the good guy. Nobody works with LDL except for B100. So that's why when you're missing B100 over here in A-beta lipoproteinemia, you're losing all your LDL. And you don't want to lose all your LDL. Like, it's a bad cholesterol, yeah, but you don't want to lose all of it. You just don't want to have too much of it. Right, so anyway, hyperchylomicronemia, the name gives it to you. You're going to have too many chylomicrons, right? Chylomicrons and cholesterol. So the issue ends up being here that you end up getting pancreatitis. Right? Remember, pancreatitis is always going to be a big deal when you have too much cholesterol in the patient. Pancreatitis, and this is a notorious thing they can give you in a question, a creamy layer in the supernatant. When you take the blood and you run it in a machine and you make the supernatant form, it's creamy because of too much chylomicron. Type 2 is, there's 2 different types. There's the 2A and 2B. You don't really have to worry about it too much. But the issue is, I always remember this as too much LDL because that's the most notorious issue there is. They have a defective LDL receptor, right? Or they have a defect in only ApoB100. So essentially what ends up happening is they can't pick back up their LDL. So LDL is just going to be circulating in the blood. So because of circulating LDL, what do you end up getting? Well, you end up getting accelerated atherosclerosis that can just lead to an MI in a very, very young patient. Alright? Atherosclerosis in a very young patient. Then you have dys-beta lipoproteinemia, which is type 3. I always remember type 3 ending in 2 E's, the number 3, right? The way you spell 3. So this is type 3. And the letters in 3 will remind you that the issue is defective ApoE, right? And when you don't have ApoE, remember E for everything. ApoE's job, if you go back up here real quick, ApoE picks up everything except LDL. Right? Its job is to bring back everything except LDL. So now when you look at over here, dys-beta lipoproteinemia, you end up having everything in the blood. And part of that was VLDL. Right? You're supposed to be picking up VLDL too with ApoE. If you don't pick up your VLDL, this only breaks down into LDL, right? IDL and then LDL, which is bad still. So this ends up presenting with a very similar ending as type 2. You end up having atherosclerosis, right? Except that the type 2 is significantly more worse, and type 2 is autosomal dominant. The even ones are autosomal dominant, 2 and 4. Type 4 is more similar to type 1 because, again, you're going to have triglycerides, right? You see how in type 1 chylomicrons and triglycerides were an issue? Type 4, again, you have triglycerides, but this time with VLDL. But it's the triglycerides, the high amounts of triglycerides that ends up causing hypertriglyceridemia, which can, again, lead to pancreatitis, right? But in this scenario, this is very much like an obesity kind of thing with hypertriglyceridemia. So you also have insulin resistance. Okay, and that's really all there is. Now, as far as physical exam goes, type 1 is the one that has the eruptoxanthomas, which is stuff we're looking at right now in cardiovascular. Type 2 is the one that has the Achilles tendon xanthoma and a corneal arcus. Whereas type 3 is the one that has your palmar and tubular eruptor xanthomas. Right? Completely different scenarios for all 3 of them. You won't get, for example, the Achilles tendon xanthoma in type 3 or type 1. It doesn't work like that. Right? Those specific ones happen in those specific scenarios for various reasons that you don't really have to worry about too much. But just know them. Just know them like that and memorize it in that way. Right? So that's what we just saw a glimpse of right here. And then they go on to talk about arteriosclerosis. There's 2. There's arteriolosclerosis, which is for arterioles. And then there's monkey-bird sclerosis, which is a little more rare. Arteriolosclerosis is very common, and it affects small arteries and arterioles, hence the name, arteriolosclerosis. There's 2 types. There's the hyaline type, and then there's the hyperplastic type. The hyaline one is due to hypertension. Right? Generally speaking, hyaline is always going to be due to hypertension. But most likely, generally speaking, hyaline is going to be due to diabetes. As we can see this one right here. This image A is basically your hyaline, and this is due to diabetes. So diabetes, arteriosclerosis is usually going to look just like this, right? And it's hyaline. Hyaline meaning it's very like smooth looking, and it's because of sugar. Whereas hypertension is going to be hyperplastic. It's going to look like this, with the onion skinning kind of thing going on. Right, so that's your two different kinds of arteriosclerosis. In here, in image A, what you're actually pointing at is what they usually call a Kimmel-Wilson, something like that, nodule. Right, that Kimmel nodule, let me just check what that was called. I don't know why I'm blanking out today right now. I guess I'm just tired. Kimmel-Wilson, I think. Kimmel-Wilson. So the Kimmel-Wilson nodule is what you're seeing here. That's a nodule that forms in arterioles in diabetic patients. That's what you're going to be seeing right there. Right? And then this one here, this onion skinning kind of thing, which is actually very well named, calling it onion skinning. This is the thing you see in hypertension. Right? Two different types. And I talk a little more about it on the side. The thing you see over here in X-ray image C, this is uncommon, monkey bird sclerosis, or also known as medial calcific sclerosis. It affects medium-sized arteries. There's calcification of the internal elastic lamina and the media of arteries, leading to vascular stiffening without obstruction. So you end up getting what they call a pipe stem appearance, right? And it's just weird. This is not normal looking at all. They're not supposed to look like this. And these are pretty big arteries, right? They say medium-sized, but they're pretty big-looking arteries. It does not obstruct blood flow, and the intima is not involved, which is why it doesn't obstruct blood flow. Whereas arteriosclerosis, as the intima is involved, you clearly see blood flow will be obstructed. Right? So here is concentric, as I wrote right here, concentrically towards the lumen. So it's going to be, B was concentric. In image C, the internal elastic lamina, the intima itself is not affected at all, just the internal elastic lamina and the media is affected. So your vessel lumen will be fine, but the outer area gets bigger. Right? So that's why it looks so thick in this X-ray. And anytime you get a question on monkey bird sclerosis, it's usually going to be in the legs. You don't get it in the arms, you don't get it in the chest or the abdominal area. You just get it in the legs. And they're going to give you an X-ray similar to this if they want to give you an X-ray. If they're not giving you an X-ray, then it's just going to be a description of very weird, bent-looking blood vessels, but the flow should be fine. So they'll tell you, like, you could feel the pulses at the ankle. You should be able to feel pulses just fine, the femoral pulse, but the artery should be looking weird. They might even give you like a physical exam kind of picture of the leg itself, and you can see it over the skin also, under the skin. Right, other than that, A and B, so anytime you see an image like A, think of diabetes, and this is diabetic issues of the vessels, blood vessels, non-enzymatic glycation. Whereas image B, anytime you see something like this, think of hypertension, right? And you're concentrically growing into the center, right? What they're doing here in image B, what your body's trying to do is, there's so much pressure inside the lumen that you're adding more and more concentric layers of muscle to be able to withstand that pressure. This is the same exact thing your heart does too, leading to hypertrophic cardiomyopathy, right? When you have a lot of hypertension in your left ventricle because your aorta doesn't want to let your aortic valve open, then your left ventricle tries to hypertrophy by adding more layers of muscle concentrically, right? And that leads to diastolic dysfunction because you can't actually fill blood in there. Same thing here too. You can't fill blood into this lumen because it's mostly obstructed. Now, if they wanted to give you an image of the monkey bird sclerosis, it looks like this. So I put that here too. Right? This is the histological slide similar to images A and B. Image C should have been like this, where this is monkey bird sclerosis. The reason you could tell this is monkey bird is because first things first, you can tell the lumen is fine, right? Blood flow is going to be okay, but the vessel itself, you can see there's something wrong in the media. Right, and that is exactly how monkey bird sclerosis is medial calcific sclerosis. Right, the really dark purple stuff is actually calcific sclerosis, and it's medial. Medial is actually in the middle, so it works out fine. It affects your media of the arteries. but it doesn't affect the lumen, so it doesn't actually affect your blood pressure either, right? Blood pressure won't get affected, at least not significantly, but it does affect how likely it is that this blood vessel will be compliant, right? This blood vessel will not dilate and constrict as necessary that well. It's not going to be that compliant at all. Okay, so those are little things you want to watch out for. And then now we come to the really big topic that I'm going to try to speak about as perfectly as possible, which is atherosclerosis. Right? Everyone, generally speaking, when you're studying for step 1, everyone picks up atherosclerosis very well and understands it. But then there's always that one scenario where you end up getting a question on atherosclerosis and you're like, alright, shit, I got this. You read the question and then you're like, what the fuck are they asking? And it just becomes really confusing, and all the answer choices end up looking correct. So you need to know the pathophysiology of exactly how an atherosclerotic plaque forms, what started it, what was the first step, what are all the different parts of an atherosclerotic plaque, and what makes the plaque finally rupture and lead to other issues like a stroke, an MI, etc. So these are 2 images. This one down here is from Amboss. It's the progression of an atherosclerotic plaque. You can see that they labeled it with the time chart at the top, and it's taking decades, right? So it takes a very long time for an atherosclerotic plaque to develop and become big, right? And then in the ending, they wrote minutes. But you see in the middle right here, it says clinically significant. It's only clinically significant in these 3 stages here because now it's obstructing your lumen, right? The lumen is becoming thinner, which means your blood pressure is going to start going up, blood flow is not going to be that good, and if you block that much of it, then essentially your lumen is only that big, and that's very high blood pressure, right? And then this last 2 parts, 8 and 9, it says it takes minutes. It takes minutes for the rupturing and other issues to take place with the thrombus. This last part is really dark red up here. That's a thrombus. You've completely blocked off this lumen now. And if this is your coronary artery, the left coronary artery, right coronary artery, which one? You can get an MI because there's no blood flow, right? And if this is any other artery, depending on what it leads to, that part of their body is going to have ischemia because there's no blood flow. So let's take a look at the parts first, right? This up here shows you the parts of an advanced plaque. So there's two main parts. There's your fibrous cap, and then there's the whole necrotic core itself, right? With the atheroma. The fibrous cap, you have to remember, is always actually a product of smooth muscle cells coming from the body itself, from the vessel itself, smooth muscle cells. Rather than that, everything else is insignificant here, but smooth muscle cells are what make your fibrous cap. In your atheroma itself, you have to remember that there's a lot of foam cells and calcium. Right? Foam cells and calcium, which actually makes this a little hard. It hardens it. It becomes a little stiff. Right? And macrophages are doing their best to eat everything up, but they can't, which is why they become foam cells and they just end up bursting again. Right, so when we look at over here, I'm going to read off the notes for numbers 1 through 9 because it's a little tiny. But right here, starting off in the beginning, it's normal endothelium, right? Then you have endothelial cell dysfunction, which is going to be the starting or inciting event, right? You have to remember that. You can get a question talking about an atherosclerotic plaque, and they might be like, what was the inciting event? What was the thing that started this stuff up? What caused the initial drama? The initial drama was some kind of endothelial cell dysfunction. So you see here chronic stress, either due to hypertension or inflammation or whatever it might be. But there's chronic stress, and that's what's starting it. Then you're going to have more VCAM1 expression because of that chronic stress. So you can see now there's like an uplifting thing happening here. Right, VCAM1 expression. Now number 3, infiltration of LDL and monocytes, resulting in accumulation of macrophages and oxidized LDL. Right, so you see how now stuff is starting to accumulate down here. You have a little bit of a yellow layer. Now the problem has already started. And within decades, up to image 6, it's going to start getting bigger and bigger. So after this stage, now we look at number 4, what's happening here? Well, by this point, you formed what they call a fatty streak. Right, a flat yellow with irregular borders streak. That's what this is. It's a foam cell formation resulting in fatty streak. What is a foam cell? The foam cell are all the macrophages that are trying to eat all of this lipid and get rid of it, eat all of the cholesterol and get rid of it, but they can't. They'll eat it, but then it just stays inside them, and they also end up becoming what the human itself is, really full of just fat and obese, and then the macrophage becomes pretty dysfunctional at that point. Then you have proliferation and migration of smooth muscle cells and the extracellular matrix deposition. And you can see here PDGF and FGF are involved, right? PDGF and FGF are involved. They are now kicking in, trying to do things, fix stuff up, trying to resolve this issue, make space for all the fat, but at the same time maintain the integrity of the lumen of the blood vessel. But it's not working out, right? Because you see how much you've obstructed almost more than 50% of the entire lumen. It was so big before, now more than half of it is covered up. So eventually this keeps going and you reach an obstructive phase, right? And this is when it's becoming clinically significant. So let's say maybe it's been like 20 years now. When it first started, it was right here. From there to here, it took 20 years, or maybe even 30, 25, whatever. And that much time, now you've reached this phase. And this only happened because this is a person who never went to the doctor or never started taking their statins, right? Never started taking their statins, never tried managing their cholesterol, right? So what they're showing you here is something that's happening to a person who is not trying to maintain themselves, take their medications, and have regular doctor visits. This won't happen to a person who is maintaining themselves, taking their medications, and maintaining regular doctor visits. Right? So this is from not going to the doctor. Now, after this, your obstructive phase, within minutes, one day, the plaque will rupture. And they're going to ask you, they're like, what caused the plaque to rupture? The answer for that is your metalloproteinases, right? So this right here, they wrote plaque rupture due to increased matrix degradation, and the matrix degradation is due to metalloproteinases. They do that, it ruptures, all the plaque stuff is going to start coming out, which can actually lead to a stroke. But at the same time, platelets are going to realize that this kind of stuff is happening, and you're going to have a thrombus. Thereby, now you're pretty much occluding 100% of the lumen, and blood flow is now impeded. Alright, so there's no more blood flow anymore, and that's going to be problematic, and this patient is pretty much just going to end up having a heart attack if this is the heart. If this is any other part of the body, then they'll have pain over there. Okay, so that's that. Now let's take a look at it in the book itself, right? Atherosclerosis. So let me see, let me move this up. Okay, there you go. Now we can fit the whole thing here. Alright, so let's just read what the book has first. So atherosclerosis, very common, of course, and very high yield for your test. Disease of elastic arteries and large and medium-sized muscular arteries, a form of arteriosclerosis caused by buildup of cholesterol plaques. Right, and arteriosclerosis was usually due to diabetes or hypertension. Now you have plaques building up in there too. So first things first, you need to know where it can occur. Right, what are the top most popular places it can occur? And you will definitely get a question. They'll ask you, they'll be like, oh, this person had an atherosclerotic plaque. Where's the most likely location of the plaque itself? It's funny that they gave you a picture of the carotid artery here, because the carotid artery is the least likely spot to actually get the atherosclerosis. But least likely doesn't mean it won't happen. It's still a pretty high likelihood it can happen. It's just relative to the others, it's the least likely. Alright, but the carotid artery is still pretty likely, and that's how it looks like gross, on a gross image. Abdominal aorta, though, which is pretty easy to remember because we just spent some time talking about abdominal aortic inflammation and Marfan's and all that, aortic aneurysm, right? So your abdominal aorta is the #1 most likely location for you to have atherosclerosis. After that, it's your coronary arteries of the heart, which is actually going to cause chest pain and stuff like that. And then you have the popliteal artery, and lastly, the carotid artery. Right, so abdominal aortic aneurysm in a person with atherosclerosis and a smoking history is a really big deal. Coronary artery aneurysm is definitely going to be a problem in someone who feels chest pain, especially when they try working out. Right, and you could do a stress test to actually diagnose them and see if they have a coronary artery atherosclerosis. Popliteal artery, if you have popliteal artery which is in your leg, atherosclerosis, then you'll get something known as intermittent claudication, which I have a little note about on the top. So when this person tries using activity of that leg, they're going to start feeling pain in that leg. Right, and then the last one, carotid artery. So you can actually palpate that. When they have carotid artery atherosclerosis like that, you will be able to palpate that. Pulses will be weaker. You'll know it's happening. And all of these can be fixed with surgery to a certain extent, but it's still really problematic. It's better to just avoid it from ever even happening. So they then tell you, right, risk factors. Modifiable risk factors are you quit smoking, you manage your blood pressure, you manage your diet and take medications to reduce LDL like statins, and you manage your diabetes. Manage them. Manage them the best you can, right? Now, remember, one mistake doctors are making all the time is telling people to just completely stop something. No one is going to completely stop doing something they've been doing, even though they know it's bad for them and they like doing it. Right? It's just a fact. We're all guilty of it, right? Everyone likes doing something that's really bad for them, and they know they shouldn't be doing it. Smoking is up there with that, right? Smoking is definitely one of those things. No one out there that smokes knows, oh yeah, this is great for me, right? They all know. Every smoker knows it's bad for them. You don't need to tell them to completely stop smoking. Tell them to slow it down, cut back, right? Cut back. Don't tell someone to completely give up sugar. Tell them to cut back, manage it better. Pick a day of the week where they'll spoil themselves, but then the other days don't have much sugar at all. You know, stuff like that. You need to come up with good ways of dealing with patients rather than just telling them, yo, just stop eating sugar, stop smoking cigarettes, control yourself. No one has self-control. Self-control is a very difficult thing. It's very easy to talk about, not easy to do. So these are all the modifiable things that you really want to be able to tell your patient to cut back on and manage, right? Take your LDL statin medications, take your hypertension medications, take your diabetes medications, and cut back the smoking. Alright? Non-modifiable things that you can't do shit about are age, sex, and family history. Right? It's higher in men and postmenopausal women. Right? And why in postmenopausal women? Well, I wrote over here, a decrease in estrogen leads to a decrease in HDL, which is the good lipid. Right? So if you didn't know that, now you know it. This point is actually brought up again later on when you get into reproductive. Right? But I had to put this note here. It's actually better that way. I want to fix something here that's bothering me. Can I just bring this down? Okay, there you go. That looks a lot better. Okay, so that's your two modifiable versus non-modifiable risk factors. Then they have symptoms. What are symptoms of all of this atherosclerosis? Well, you're going to have chest pain, especially mostly if it's in the coronary artery. You're going to have claudication if it's in the popliteal artery. But generally speaking, it can be asymptomatic, which is why people who do have it in their abdominal aorta end up not ever having any symptoms until they're much older, right? Because remember, this takes decades. So maybe an elderly white male who's about 72 years old might have an abdominal aortic aneurysm because they have inflammation. Atherosclerosis is an inflammatory process, remember that. And this inflammation will lead to the weakening of your blood vessels. So they go on to tell you now the progression of an atherosclerotic plaque, which is exactly what I was showing you here, and exactly what you're definitely going to have a question on. So first things first, inflammation is important in the pathogenesis. The first thing that happens, as I said earlier, is endothelial cell dysfunction. This leads to macrophage and LDL accumulation because your endothelium is no longer perfect, so macrophages and LDL came in. Then they, well, not eat each other, I was going to say then they eat each other, but then macrophages eat the LDL, so you get foam cell formation. All of that foam cell accumulates and you make a fatty streak. Think of each one of these arrows to be like 2 to 3 years. 2 to 3 years each time you see one of these arrows. All of that fatty streak causes more inflammation, leading to smooth muscle cell migration. And this involves PDGF and FGF, like we saw right here. Right, this step right here. Yep, PDGF, FGF, right? The fibroblast growth factor, all of that leading to you getting smooth muscle cells, the red stuff you're seeing here, to be called in. Right, and I told you earlier that all those smooth muscles, the smooth muscle cells, that's what's going to help you form your fibrous cap. So when we come back to here, we can see smooth muscle cell migration thanks to PDGF and FGF. You get proliferation and ECM deposition, extracellular matrix deposition, which all helps you make your fibrous plaque, and you get a complex atheroma. The fibrous plaque is thanks to the smooth muscle cap. That's what they're talking about when they call it a fibrous plaque. It's your fibrous cap, same thing. And that's pretty bad, right? That's really bad. Fatty streaks are the earliest lesions. That's the first lesion you're going to see from all the foam cells that are accumulating. The fibrous cap is synthesized by smooth muscle cells, right? Really important notes that are here because those are the little tiny things you get questions on when you finally start doing UWorld And of course, you'll see it on NBME and most importantly, your step 1. So what they're showing you here now, right, this looks a lot like the monkey blood sclerosis thing we saw, but it's not. There's no dark calcific stuff, right? Calcium looks purple. There's no calcific stuff here. There's actually a big ass, shithole over here. That is your atherosclerotic plaque. And you see how the lumen became smaller now? So blood pressure will be high, right? So then again, even in U-World, they have this little bullet point way of telling you the progression of an atherosclerosis. Same thing again, you repeat it. Every time you need to read it, you keep reading it. Endothelial cell dysfunction, accumulation of LDL in macrophages, right? Monocyte adhesion to the endothelium, followed by migration, so you get foam cells, right? So LDL in macrophages, you get foam cells. Release of growth factors like PDGF and FGF, they're both growth factors. Platelet-derived growth factor and fibroblast growth factor. All of that stuff is eventually going to lead to your fatty streak, and then recruitment of T cells and smooth muscle cell proliferation leads to your ECM production, making fibrous cap, and then boom, you have your atheroma, right? Step by step. You have to know it very, very well. Up here is again from older U-World. This is from the newer U-World. This is from an older U-World. A complete breakdown of how it all happened, right? So you could read that, but one important thing that I want to point out again is the metalloproteinases. Metalloproteinases are the ones that are going to lead to the ending over here where you finally end up rupturing the plaque and making a thrombus. And this is when the person is now going to have crazy symptomatic issues because of the atherosclerosis. And then I'm going to read the note at the top. So I wrote, LDL builds up in the intima and they are strongly attracted to proteoglycans in the vessel wall. If the LDL remains in the vessel wall, they become oxidized and that produces radical oxygen species which damage the endothelial cells, right? That's how it all started, endothelial cell dysfunction. This leads to release of VCAM1 and monocyte chemotactic protein, MCP1, which brings monocytes into the wall. The obstruction of large arteries from stenotic atheromas can cause exercise-induced muscle pain that remits with rest. So exercise-induced muscle pain that goes away when you stop exercising. That is called intermittent claudication, which is always a big sign of something wrong with your blood vessels, and in this case, atherosclerosis. Thigh claudication is suggestive of occlusive disease of the external iliac or common femoral artery. Aortic-iliac atherosclerosis, known as Leriche syndrome, affects the internal pudendal and internal iliac arteries, causing impotence and gluteal claudication. And this note actually came from a U-World question where they talked about this, right? Exactly like this. So you had a weird patient, you had a patient with a weird issue, right? For some reason, this guy was having intermittent claudication when he tried working out, and he was having impotence. And what you had to realize that impotence is strongly due to blood flow not going correctly, right? That's the biggest issue. That's why taking a vasodilator can help. But in this guy's scenario, it wasn't that he had any medication he was taking that was causing impotence. Nothing else. The intermittent claudication plus impotence combined is actually supposed to ring a bell in your mind for atherosclerosis. And of course it was atherosclerosis of your internal pudendal artery or the internal iliac artery, because that's what's going to be connecting the two things, right? Internal pudendal is connecting impotence and exercise together because they both are related to pudendal artery having the correct amount of blood supply. That's a very interesting disease that they picked to talk about atherosclerosis. Okay. And then I already mentioned VCAM1 here, but there's also something called MCP1. Of course, these are little tiny things that can come up, most likely on NBME rather than Step 1. Step 1 doesn't like picking on shit like that, but NBME definitely does. Alright, so if you have to take an NBME still, there's that. At the end of the day, if you don't fix this and you don't manage yourself and you don't take care of yourself because you really hate yourself so much, you're probably just going to die, right? And they don't put that here in complications, but that's most likely what's going to happen. So they wrote here complication, aneurysm, ischemia, infarct, peripheral vascular disease, a thrombus, or an embolus. All of which are little tools that can definitely kill you. And the patient may have sudden cardiac death due to malignant ventricular arrhythmias and ventricular fibrillation, which is the most common cause of sudden cardiac death anyway, right? We already saw that at the end of cardiovascular physiology. Alright, so that takes care of atherosclerosis. Now let's move on to other things that can happen to your blood vessels in terms of blood pressure or some kind of inflammation. We already talked about your abdominal aortic aneurysm, so now we're actually at aortic aneurysm from that question we did. Right? There's abdominal aortic aneurysm and there's thoracic aortic aneurysm. The thoracic one is up here, so that's above your renal arteries, above your kidney. Abdominal aortic aneurysm is generally the one that's going to be below your kidneys, below your renal arteries. So this is a localized pathologic dilatation of the aorta. May cause abdominal and/or back pain, which is a sign of leaking, dissection, or imminent rupture, as in rupture that's about to happen. Because this dilation, so your abdominal aorta is actually a very, very thick artery. It's very strong, and if you dilate it, it becomes very thin and weak. But remember, there's very, very high pressures in your abdominal aorta, in your aorta in general. So if you have a thin aorta with high pressure, it's just going to burst, right? And you can see that right here. This is a thoracic aortic aneurysm. Let me make this a little bigger. Right, thoracic aortic aneurysm is up here. Abdominal aortic aneurysm, you can see, is below the renal arteries. Okay, and this is just going to rupture. It's very swollen. It's going to rip, and then that's going to be problematic. Okay, so that's what we're looking at right here. So let's take a look. Abdominal aortic aneurysm. This is associated with atherosclerosis because remember, your abdominal aorta is the #1 location of atherosclerosis. Risk factors include history of tobacco use, high age, male sex, family history. May present as a palpable pulsatile abdominal mass. Right, arrows here actually point to the outer dilated calcified aortic wall with partial crescent-shaped non-opacification of the aorta due to a flap or clot. That's what you're looking at in this image right here. Other things don't look like this at all. So when you do see this, that's an aortic aneurysm. Right, so you can see your whole aorta is actually that big. And then that crescent gray moon that's right there, right? The gray area right there, that stuff is your flap or the clot, whatever is actually just starting to form in your abdominal aorta. The white area is just the opening of the lumen where blood is actually still flowing correctly, but it's dilated. It's not supposed to be that big, right? It's almost the size of your spleen. That's huge now because you see how dilated it gets. It gets huge. Most often infrarenal, distal to the origin of the renal arteries. And then you have your thoracic aortic aneurysm. The thoracic aortic aneurysm is not due to atherosclerosis. You actually have really good blood supply in your thoracic area, and you have your vasa vasorum there too. Your vasa vasorum is there from above the renal arteries. So there, the issue is actually Marfan, and it's associated with cystic medial degeneration. Right? There's a cyst, and there's medial degeneration of the tunica media. Risk factors here are going to be hypertension, a bicuspid aortic valve, so this could be a Turner syndrome patient. If you get a Turner syndrome patient and the question looks like this leading to aortic aneurysm, make sure you pick thoracic aortic aneurysm. Or anyone with connective tissue disease, such as Marfan, Ehlers-Danlos, etc. Also associated with tertiary syphilis, which when we did our microbiology, we talked about the obliterative endarteritis of the vasa vasorum. Right? All your syphilis is actually going to go into your vasa vasorum and start destroying it. And that's pretty bad. The last thing they talk about here is aortic root dilatation may lead to aortic valve regurgitation. And how did that happen? Well, basically, you can see that this dilation can keep going up and up. Right? It's just going to keep expanding upwards. So then you can have dilation over here. And if you pull apart your aorta, you're going to pull apart the aortic valves, and that's just going to cause more issues over there in the heart. Right, so that's why you have aortic valve regurgitation, because if you pull the valves apart, they're going to start opening inwards and blood is going to come back down into the left ventricle. So let's read some of the stuff I wrote. 2 types of aortic aneurysms, thoracic or abdominal. Patients will present with pain due to the stretched aorta pushing on the surrounding structures or nerves. In addition, if there's a rupture, then the blood can directly irritate the nerve because blood is irritating, it's inflammatory itself. I said that earlier too in the last video when we were talking about your coarctation of the aorta. So you make peripheral blood vessels, collateral blood supply under the ribs, and that causes notching of the ribs because blood is very inflammatory. Usually, an elderly white male with smoking history and a pulsatile abdominal mass with low blood pressure due to bleeding into the retroperitoneal space. In CT, you can see abdominal aorta below the bifurcation of the renal vessels where there is no vasa vasorum, so oxygen and nutrients cannot reach out from the lumen. Atherosclerosis induces chronic transmural inflammation, leading to an aneurysm. Might note a decreased ankle brachial index, which is usually seen in peripheral artery disease due to the decreased blood flow to the lower extremity. Right? That's a pretty nice tiny point to keep in mind because it hasn't been mentioned before. So let me actually put that in bold. Common format. Okay, right? Because that ankle brachial index thing is something that you might not think of really, but it's definitely something that makes sense, right? We saw differential cyanosis when we talked about patent ductus arteriosus, and then we saw an ankle brachial difference in blood pressure with coarctation of the aorta. Coarctation of the aorta did not have differential cyanosis. It's just that not enough blood was actually going downwards, so the pulse is weaker in your ankle. Here, same kind of issue. The pulse is going to be weaker at your ankle, right? Because there's inflammation and issues happening in between upper and lower body. Thoracic aorta is right where the aorta leaves your left ventricle, and the thoracic aneurysms are often associated with hypertension unless the patient is young. Then you consider connective tissue disease like Marfan's or Ehlers-Danlos. There's also tertiary syphilis, where the spirochete treponema pallidum can invade the vasa vasorum of the aorta. Cystic medial degeneration presents with myxomatous changes, characterized by fragmentation of the elastic tissue, leading to a basket weave pattern and separation of elastic and fibromuscular components of the tunica media by small spaces that fill with amorphous matrix. Right? So now you know the whole picture of an abdominal and thoracic aortic aneurysm. You know exactly what's happening and what the difference is between the two. So don't get them mixed up, don't pick the wrong one, and know the associations. Know what's related to each one of those difficulties. And on top of that, now you also know how it looks like on the CT. And this is just one image, right? A book isn't going to be full of images, so you should go ahead and look for more. Look for more CTs of how a thoracic aortic aneurysm looks like, how an abdominal aortic aneurysm looks like, and so on. The image they've given you here is definitely your thoracic aortic aneurysm, because you can still see the liver, you can still see your spleen. They tell you that it's an abdominal aortic aneurysm, but it's really hard to get that because your abdominal area would not really catch the liver and spleen, per se. If you're that far down low, it should be you shouldn't be able to. Wait, what am I wrong? I am wrong. Sorry, what am I saying? This is definitely your abdominal. See, this is why it's good to practice these things. This is definitely your abdominal stuff, because down there is where you have your liver and spleen. If it was thoracic, if you were looking at a thoracic aortic aneurysm, you would see 2 lungs. Right? So that's how you want to make sure you catch the correct picture. So if you get a question about someone having a thoracic aortic aneurysm and they give you a CT, that CT should have 2 lungs, because up here you have lungs, right? 2 lungs on both sides, and then you should be looking at the aorta, and most likely they'll be showing you the descending aorta, so you should also see the ascending aorta in that same image, right? Practice that. Anytime you get a CT of up here, you can see both the ascending aorta and the descending aorta at the same time, so you'll see 2 openings. Right, and most likely the issue will be in the descending aorta. This image here, image A, is your abdominal stuff, because in your abdomen is where you have your liver, your kidneys, your spleen, stuff like that. Okay, so that's that. Now let's move on to other stuff. This is a really easy one up here, the traumatic aortic rupture. This can occur to anyone that has a really bad car accident. It's due to trauma and or deceleration injury, most commonly at the aortic isthmus. Right, which is proximal to the descending aorta, just distal to the left subclavian artery, which is pretty much right there. Right, aortic isthmus is labeled here, so right there after the left subclavian artery. And what happens is, if you have a sudden deceleration, then everything pulls in one direction, but the descending aorta won't pull. So basically, you end up pulling these 3 guys to the left, and you just rip it at the aortic isthmus, and that's really painful, and you're going to have a lot of hemorrhage, and the patient can pretty much die. Right? An X-ray may reveal a widened mediastinum, but that's not exactly the most important thing to look at that point. By now, the patient is probably showing up with a lot of pain, very low blood pressure, internal hemorrhage, etc., etc. Right? This here is the myxomatous degeneration that you're going to see now when we get to aortic dissection. Right? And myxomatous degeneration is also the same stuff you see in a thoracic aortic aneurysm from the Marfan and connective tissue disease. Cystic medial degeneration. So you can see myxomatous degeneration in thoracic aortic aneurysm too, but here we're talking about it in sense of aortic dissections. That's the next issue. What is an aortic dissection, and how is that different from aortic aneurysm? Right, 2 completely different words. Dissection is a ripping, whereas an aneurysm is a bloating up, and it's about to explode, right? It's going to blow up on you. So that's the aneurysm we saw right here. It's about to blow up. Whereas here we're looking at something that's pretty much ripping. And this is usually going to be associated with hypertension. The number one issue that leads to aortic dissection is hypertension. Too much pressure on your aorta chronically. So you can see how it ripped, right? All the pressure ripped into it. So now you have two lumens. You can see two separate lumens formed in here. So let's take a look at aortic dissection now. So longitudinal intimal tear forming a false lumen associated with hypertension, bicuspid aortic valve, inherited connective tissue disorders like Marfan syndrome, which is why again we're seeing myxomatous degeneration, can present with tearing, sudden onset chest pain that radiates to the back. Right? Very important presentation. Usually every question I've seen about an aortic dissection started off exactly like that. Okay, and then it's also going to have unequal blood pressure in the arms, right? Depending on where the dissection occurred. So you see how when I was talking about if you look at your CT up here, you should see the two lungs. So that's what we're seeing here. They cut off most of the picture, but you see how on the left and right it's all black space. So those are your lungs. Those are your lungs. And then I also mentioned that you should be able to see, if I do a cross section here, you should be able to see ascending and descending aorta, so you can see both. You can see both of them. So that's that. And of course you should be able to figure out which one is which. So this descent happens behind, right? So this is your ascending aorta and this is your descending aorta. Okay? So now chest x-ray can show mediastinal widening once again, just like we saw with this, right? Thoracic aortic rupture. Can result in organ ischemia, aortic rupture, and death. And there's two types. There's the type A and type B. Okay, type A and type B, and that's what I'm showing you in these two pictures here. Type A is proximal, and it involves the ascending aorta, which is really easy to remember. It may extend to the aortic arch or the descending aorta, may result in acute aortic regurgitation or cardiac tamponade. So the A is really problematic because it can just go in both directions like crazy. You see how the A expanded entirely to the whole aorta? Because you're literally ripping into the skin of the aorta and then just taking the whole thing up. So that's what's happening. You see how you rip into it, and then this can just keep going and going and going all around the aorta, and you just cause this really weird looking weak aorta. It can also come forward and cause tamponade like that, right? It can come forward, engulfing the rest of the heart and causing a tamponade because the skin basically of the aorta is coming off. That's kind of how you want to see it, and that's really problematic. Type B is below the left subclavian artery, right? It's later on. After the left subclavian artery, it's just like that. All right. So for type A, the only thing you can end up doing is surgery. You have to do surgery to fix this. Otherwise, it's going to expand to both directions, front and back, and it's just going to mess everything up. Type B, you actually give beta blockers to first slow down the heart rate, and then give vasodilators to fix the blood pressure. Okay, so type B is medically treated, whereas type A is surgically treated. And one extremely important fact that I want you guys to pay attention to is something that you will put in a lot of effort to teach, which is that an aortic dissection is not really related to smoking at all. You know, I find it hard to believe. I think that smoking does kind of weaken the lumen and allow this rupturing to happen in addition to hypertension. So I find it very unfair to try saying something like smoking has nothing to do with aortic dissection. Of course it does. It's weakening your blood vessel. But UWorld and of course even First Aid, you could see it. They didn't mention smoking at all under aortic dissection when they mentioned associated with in the second sentence, right? They said associated with hypertension, connective tissue disorder, bicuspid aortic valve, which is also related to hypertension. So, you know, you have to keep in mind that an aortic dissection has nothing to do with smoking. Just for test purposes. Keep that in mind. Right? Otherwise, like, it doesn't matter. That's just something. UWorld has a question where they ask you that too. I think I can find it somewhere. Yeah, right here. See? This is another picture of your thoracic CT. And you see how you can see both sides are just lungs. You see your ascending aorta. You see your descending aorta. You can see there's a false lumen. So this must be a person who has an aortic aneurysm. Sorry, not aortic aneurysm, aortic dissection, right? This is a dissection. You created a false lumen. If this was an aortic aneurysm, this would all be gray, This would be filled in gray, not see-through like that. Filled in gray, and that would be an aneurysm because it's pretty much a clot or a flap or something. Anyway, this is aortic dissection. You have a false lumen. The lumen and the real lumen are pretty much the same color here. And how did it occur? So they see which of the following is a single most important risk factor for this patient's current condition. Now, I like the fact that they worded it like that because the most important risk factor is definitely hypertension. Well, smoking is a risk factor too. It's just they don't really want you to think of smoking when it comes to this. Alright? So of course you're never going to get a question of which one of these things is definitely not a risk factor and then you pick smoking. That's never going to happen. Keep in mind that the most important issue with abdominal aortic dissection is that you have hypertension. Unmanaged, unrestrained hypertension. So much pressure that you ripped into your aorta and then you cause either type A or type B kinds of issues. Alright? So that's it for that. In the next video, I'll go ahead and go into angina and things that are related to your coronary artery having atherosclerosis, because all of this chest pain and stuff, unmanaged, eventually either leads to sudden cardiac death or you have an MI. Okay, so we'll talk about that stuff in the next video and go into a lot more pathology. Just make sure you go over the stuff we talked about right now. Make sure you can get it into your mind, how they occurred, what caused it, what was the related or associated risk factors, and how you're supposed to deal with it, even if you could. Most of them you can't deal with, you're supposed to prevent. Prevent it from ever even getting to that level. Manage your blood pressure, manage your diet, manage your statin intake, your fenofibrate intake if you need it, whatever pharmacology you have to deal with. And yeah, keep it up, keep learning, keep doing practice questions, and then I shall see you guys later on to continue from right here.